Hi everybody, this is Corey Hill from the Partnership for People with Disabilities at Virginia Commonwealth University. I want to welcome you to our October Talks on Tuesday. Before we jump into the webinar, we want to remind you that you received 4 handouts prior to this session. These will be referenced throughout the webinar today, so we wanted to be sure you had those ready. You'll also see that Jeannie has just posted those in chat, so you can readily pull those down. So today we're going to be doing part 2 of our September-October Talks on Tuesday, Family-Centered Care and the Substance Exposed Infant. Thank you again for joining us. I'm delighted to introduce Kelly Walsh-Hill and Charlene Stowers, who will be your presenters today. And I'm going to go ahead and let them introduce themselves. Ladies?
Hi everyone, I'm Kelly Hill. I've worked in pediatric therapy for 33 years. I currently work as a provider in both the NICU and early intervention. I'm also chair of the Virginia Interagency Coordinating Council. I've done webinars in the past for early intervention providers in coding, billing, and documentation, but these days my focus has been on promoting family-centered care concepts. I participated in the statewide NICU EI initiative, conducting trainings to improve family-centered care in the NICU and improve the transition from hospital to home. More recently, I've been working at my local level to establish interagency family-centered care for our babies with NAS and their families. And I had the honor of presenting at the National Perinatal Association's annual conference on perinatal substance use and NAS at Loma Linda University in March of this year. And I'm really happy today to be sharing the floor with Charlene.
Thanks, Kelly. I'm Charlene Stowers, Director of Early Intervention for the Grafton Integrated Health Network and the Infant and Toddler Connection of Shenandoah Valley. Substance use disorder and substance-exposed infants have been a passion of mine since around 2014. That was the year in our program we started to see a significant increase in the referrals of substance-exposed infants and infants with neonatal abstinence syndrome. So as a result, I was challenged then to look at my own personal biases and how I viewed pregnant women with a substance use disorder, and also look at my program and think about how we may need to do things differently to meet the needs of what I'm starting to consider an epidemic of substance-exposed infants. I would like to say that we have all the answers, but in reality we don't. Our program is a work in progress, just as many of yours may be as well. However, Kelly and I hope that what we share today will not only improve your understanding of substance-exposed infants, and infants with neonatal abstinence syndrome and their families, but also plant a seed of change in your mind in regards to how these families are viewed and how we in early intervention may need to provide services somewhat differently. Let's take a look at what we will share with you today. Today we hope to increase an awareness of how toxic stress affects the mother-infant dyad. We hope to help you understand family-centered care concepts. We hope to provide guidance in developmental assessment and treatment of the baby with neonatal abstinence syndrome. And we hope to encourage and engage early intervention programs to look at their protocols to ensure they are meeting the needs of this unique population. Understanding the substance-exposed infant and family-centered care is critical for early intervention. Take a quick guess. Using your polling device, guess how many children you think live with at least one substance-exposed parent, or I'm sorry, with at least one parent with substance use disorder under the age of 2. Looks like some answers are popping up. Give a couple more seconds if you want to go ahead and use your polling device. to select an answer, and Jeannie then will pull up the answers for everyone. Thank you, Jamie. It looks like mostly everyone selected C, and unfortunately, that is not the correct answer. The correct answer is actually B, 1.5 million. 1.5 million children under the age of 2 live with at least one parent with a substance use disorder. 8.7 million children age 17 and younger live in homes with at least one parent with a substance use disorder. But I thought it was important to highlight the under age 2, since that's the largest percentage of population of children that we see in early intervention. Many of these drug-endangered children were also substance exposed as infants. So let's take a recap about what we talked about last month and how it relates to the number of children born into this situation and their mothers who live with the daily challenges of substance use disorder. Last month I shared that substance use disorder is a disease of the brain. It hijacks the reward system, causing an unusually large amount of dopamine to flood the system. This flood of dopamine causes that high or euphoric feeling typically associated with drug abuse. When the reward system is overstimulated and the euphoric effect is produced, people want to continue to seek this feeling. Some moms end up dependent on prescribed drugs as a result of an injury. Many of these women are of childbearing age and use illicit substances to self-medicate as a result of past trauma. Did you know that 30 to 59% of women with a substance use disorder also suffer from post-traumatic stress disorder? Substance use disorder and mental health conditions are linked to traumatic experiences. Pregnant women who are continuously exposed, like I mentioned before, to domestic violence, poverty, homelessness, can be experiencing toxic stress. Many women admit to drug use as a way to manage their stress in their lives. While there still is inconclusive research on the specific effects that the drugs have on a baby, research does support that toxic stress during pregnancy can alter brain development and the endocrine system that regulates behaviors. Stress doesn't go away once the baby is born. Risk factors for continued drug use include limited resources, thinking about how to get drugs instead of parenting, mental illnesses, poor parenting, and direct behavioral influences of the drug. This type of ongoing stress can result in trauma to the baby, which can change how the infant child views the world. Prenatal exposure combined with environmental risk factors place a child more risk for developmental delays, attachment disorders, or maladaptive behaviors. Kelly is going to talk more about the impact of stress on the substance-exposed infant or the baby with neonatal abstinence syndrome.
Thanks, Charlene. So first, I want to ask you guys, how do you feel when you're sitting in a traffic jam? You've got a meeting and you're sitting still. You have no idea what's going on and how long you might be there. Use chat to give 1 or 2 words about how this makes you feel. Awesome, you guys. I'm seeing all these words: frustrated, stuck, stressed, and anxious. You're exactly right. You're getting tense. You're breathing faster. You can't concentrate on what your 7-year-old just asked you from the back seat, and suddenly you're agitated. Your body is pumping cortisol and adrenaline. And when you finally get out of the jam and get going again, what happens? It doesn't go away. Stress hormones often leave us with a headache, indigestion, and fatigue. Now compare this to the cruise ship experience. You're breathing in fresh air, you're listening to island music, and feeling warm sun. Now, use the chat again to give me a few words as to how this experience makes you feel. Awesome, everybody. Thank you. You're right. You're relaxed, you're happy, you're calm, you're excited. Your senses are heightened. You pick up on visual details, smells, and sounds are stored away in your memory, and this forms an emotion. This is serotonin and dopamine at work. These are the feel-good hormones. And later when the cruise is over, the smell of the ocean or the sound of island music can take you right back to that feeling of contentment and happiness. So now let's talk about stress on the newborn. Positive stress involves brief increases in heart rate and mild elevations in stress hormone levels. So for example, the baby wakes up with a poopy diaper and is hungry. The diaper gets changed, the baby's fed, the stress is eliminated. Tolerable stress is serious, but the response is temporary. It's buffered by supportive relationships. Here, the infant might be going through neonatal abstinence syndrome, but hospital staff are trained in neuroprotective care. The mom is there to hold her baby. The baby might be getting medication, so the stress is buffered. Toxic stress is a prolonged activation of the stress response systems in the absence of protective relationships. So in this example, the baby is going through NAS perhaps without treatment, or the mom hasn't been taught how to help her baby, and the baby remains in a state of stress and cortisol is released. Do you recall the signs and symptoms of NAS from part 1? Clinically, what we're going to be seeing here is irritability and tremors, vomiting and diarrhea, sweating and spitting, and this leads to weight loss and suboptimal weight gain. So what's happening to the developing brain in this process? When stress is positive or tolerable, a baby is able to actively perceive, learn, and organize information, manage sensory input, and transition from one behavioral state to another fairly smoothly. Positive synaptic connections and pathways result from experiences that are developmentally supportive. When a baby is in toxic stress, cortisol is released and the brain is stuck in fight or flight. Cortisol directly interferes with sleep-wake cycles, digestion, and energy conservation, and these systems are critical to early brain development. During this neonatal period of rapid neuronal cell production, neuronal mapping, and brain organization, you can imagine the long-term impact if a baby is stuck in toxic stress. So neuroprotection is the basis for the non-pharmacological strategies we talked about in part 1. And we'll talk about some of those again. Our goals in the hospital are eat, sleep, and console. We want the baby to be consolable. When we create an environment that is neuroprotective by providing swaddled containment, like you see down here, positive sucking experiences using the pacifier, skin to skin and breastfeeding, and sometimes medication, we're able to calm and console that baby. Serotonin is released, which directly improves motor and GI function, and the baby is able to slowly begin coordinating the suck, swallow, breathe mechanics necessary for eating. When full, the baby is able to sleep, where positive neuronal pathways are created. And when the baby sleeps, growth hormone is released and the baby gains weight. A baby with NAS, though, has good days and bad. They're prone to skin breakdown, poor digestion or regurgitation, and increased tone even on medication. So as we're weaning off the morphine, additional strategies are utilized, such as neonatal massage, which is known to promote weight gain, sleep, and relaxed tone. And we encourage parents and caregivers to room in or visit as much as possible to continue holding and containing their baby. We utilize peddlers, which are hospital volunteers that hold babies, and rockers to hold the babies when their families can't be there. Babies healing from NAS have been shown to respond positively to slow vertical rocking. While we know genes provide the blueprint for the formation of brain circuits, it is experiences that reinforce brain architecture. So when a baby cries, coos, grimaces, or startles, and the caregiver responds appropriately, neural connections are built and strengthened. And this is called serve and return. If the adult's response to the baby is unreliable, inappropriate, or simply absent, the developing architecture of the brain may be disrupted. The persistent absence of serve and return interaction acts as a double whammy for healthy development. Not only does the brain not receive the positive stimulation it needs, but the body's stress response is activated, flooding the developing brain with potentially harmful stress hormones. A baby healing from NAS is already experiencing physiological stress from the withdrawal. So by supporting the parent or caregiver in knowing how and when to provide the appropriate response, we can move that baby from toxic to tolerable stress and build the parent's confidence with good serve and return skills. But this can be an intimidating situation, so we work to create a welcome environment in the hospital. Whether the caregiver is the biological parent, a family member, or a foster family, they are a critical component to the healing process, and we value having them there. Education and training focuses on promoting bonding through touch, using kangaroo care, swaddling, holding and containing. We teach them how to observe their baby's responses so they can learn their baby's cues of hunger, fatigue, and stress. And then we teach them consoling and feeding strategies that meet the needs of their baby. This is where coaching begins. The parent with a substance use disorder or a caregiver who is suddenly faced with taking care of this baby may not engage in serve and return interactions easily. Recognizing their potential stress and helping them with engagement helps support the healthy development of infants and toddlers. I want to share with you what happened in my NICU. So Fauquier Hospital started universal toxicology and prenatal counseling in 2015 to identify babies with substance exposure early and prepare expectant mothers on the potential of neonatal abstinence syndrome once their baby was born. But it wasn't until 2016 that we expanded our program to a family-centered care model that included rooming in with meals, parent education, and training at bedside with their baby, and parent participation in weekly rounds. We collaborated with our community partners at CPS, and we had open, honest dialogue with families. We changed our attitude. And in 2017, 1 year later, we reduced the average length of from 33 days to 21 days. Parental touch and presence matters. Family-centered care concepts are consistent with how we engage parents as partners in early intervention. As Charlene just shared with us, parents with a substance use disorder are carrying a lot of guilt and shame. This isn't what they wanted to happen. They may have coexisting challenges with depression and anxiety. As early intervention specialists, we have a unique opportunity to support this mother-infant dyad and be catalysts for change. By showing that mother the value of her care, we give her respect and dignity. By providing transparent communication in a supportive and non-confrontational way, we educate her. We build a foundation of trust that fosters participation. When we collaborate with our community partners in pediatric health, social services, and mental health, we gain insight on this complex situation, and we're able to support one another. Optimal outcomes for these babies will only be achieved when a trusting relationship exists between parent and provider. And then one day the baby's ready to go home, often with their biological mother, but perhaps with another family member or foster family. The Virginia Code now requires hospitals not only to identify and treat substance-exposed infants, but they require the hospital to develop a discharge plan for women and their infants as a component of the plan of safe care. You might remember Charlene talked about the plans of safe care in Part 1. Federal legislation through the Child Abuse Prevention Act requires a plan of safe care be developed for all substance-exposed infants, whether they went through withdrawal or not, and that includes both legal and illegal drug exposure. A hospital discharge plan differs from family to family, but almost all now include an automatic referral to early intervention for the baby. So I'm going to turn it back over to Charlene to talk with you about the program implications we are and will be facing. Charlene?
Charlene, make sure you're unmuted.
All right, I forgot to unmute.
There you go. You're ready to go.
Okay, thank you. I apologize. Thank you, Kelly. Let me preface this part of the presentation again by saying I don't have magic answers. And some of the things that I may share with you, you may say, well, we already do this in our program. But what I do hope is to increase an awareness that these families may be as atypical as their babies. As Kelly mentioned, hospitals are required to include a referral to early intervention as part of the plan of safe care. Not all hospitals yet are up to speed with this, but the implication for early intervention programs may mean a spike in referrals. In my system, we experienced a 35% increase of referrals of substance-exposed infants and infants with neonatal abstinence syndrome in 2016. This trend is not slowing down, and there are weeks in my program where 50% of our referrals are substance-exposed infants. These referrals are challenging from what we would consider typical referrals. Often there is DSS involvement. Sometimes the child goes home with another family member and there isn't a lot of communication. Parents and caregivers may be resistant to early intervention and will avoid phone calls. If a child goes home with a parent, there may be other things in their life that are taking priority, such as sobriety or housing, or sadly even continued drug use. Parents may not be aware that there may be possible delays or that there may be anything atypical about their baby's development. Risk is defined as the chance of something going wrong. These babies are at high risk. How we make initial contact is important. I'd like to share some helpful tips for when you receive a referral. Again, some of these tips may be what you are already using, and if you are, that's great. But if you're struggling with making initial contact, maybe these will help. This is also where you might want to think about who is the first person who will be making the contact. I talked in the last presentation regarding the ability to have staff who are able to accept that substance use disorder is a disease and can approach the family with compassion and openness. Local system managers support your staff in learning about and understanding substance use disorder. Have open discussions about biases and judgments and accept that there may be some who struggle with this. Respect that, but be sure to encourage people to go in with an open mind when they're working with the family. Be prepared to be persistent in making your initial contact. Some families are dealing with issues like where to live, sobriety, and managing other children. Others may be dealing with the shame and guilt and fallout of having family members find out about their disease. And sometimes babies go home with other family members who are not aware the referral was made. When you do make initial contact, be open and honest about the referral, but ask about how they are doing. How is mom and dad? Having a new baby in the home is exciting and hard. Say, how are you? How are you sleeping? Are you remembering to eat? Are you getting any sleep at all? Start by letting them know that you care about them as a person and not about their drug use. You want to set the stage for building a trusting relationship with them. Be creative in your presentation about the program. You only have a short time on the phone with them. Have a few short talking points ready to share on why early intervention services may be helpful to them and their baby. You can say, we're an additional network of support. You might say, if they are new parents, it's nice to have someone outside the family to ask questions to. And you might remind them that even if this isn't their first baby, every prenatal experience is different, and every birth experience is different, and every baby is different. And one more suggestion regarding referral. At the bottom of the hospital referral form, when you get them from the NICU, there's a place where it states, for purposes of continuity of care, I authorize the ITC to send information regarding the status of the referral to my child's pediatrician, primary health provider, and referral source. Be sure to check if that section is signed. If it is, you are able to share with the child's pediatrician your inability to connect with the family. Intake is a great time to set the stage for trusting, partnership, and to provide education. In Part C, we are expected to suspend judgment. Suspending judgment on how clean a home may be or what type of daily routine a family may have is quite different from suspending judgment of a parent with a substance use disorder. As I've mentioned earlier, for this reason, it is very important that the staff working with these moms and dads can accept that substance use disorder is a brain disease. Intake is also an excellent time to see the whole family. Again, start out by asking mom and dad at the beginning, how are they feeling? And again, are they getting enough sleep? And what do they find most overwhelming? This is usually our opportunity to observe the family dyad and observe the serve and return action that Kelly mentioned earlier. Observation is key, since moms and dads may not be able to answer questions, or if the baby is with another caregiver, they may not have had that baby very long. This is also an important time to educate mom, dad, or another caregiver on what the latent signs of neonatal abstinence syndrome may look like. But as with any family, we should still ask about their priorities and what are their concerns. Be prepared, though, in some situations the priority may be sobriety, or following a safety plan, or getting to treatment and counseling. Their concerns may be centered around whether or not they can be a good parent, and not so much about how their baby is developing. We need to listen to those concerns and think about how we may be able to respond to them. Again, you may already be using some of the tips that I may be providing, but for this population, you want to use them in a slightly different way. It is unlikely that the baby will be asleep, or it is likely, that the baby will be asleep when you arrive. And while you admire the baby, you can look at their posture and breathing and sleeping position. Are they stuffed out when they're breathing? If they have a pacifier, are they sucking peacefully and rhythmically or frantically? If the baby wakes up, how does mom or dad or the caregiver respond to them? Do they seem bonded? What does the baby look like? How long does it take to soothe the baby? What does the environment look like? Does it seem chaotic? Is it safe? And remember, if you have concerns about safety, you need to contact your CPS. Let's chat in a moment and put in the chat box one tip that you may have, or if one of these is a favorite tip of yours. I'm going to go ahead and let you think some more about this, but I'll keep moving on in respect to time. As a reminder, it's through observation that you will gain the most important information that will be used with helping with eligibility determination. Poor parenting of a caregiver who may still be using drugs places these babies at risk for attachment difficulties. As Kelly mentioned earlier, the concept of serve and return, this is something to pay attention to when visiting the family. During intake, you may consider paying close attention or asking questions about the baby's ability to self-regulate. In early intervention, we know that a baby with neonatal abstinence syndrome or one who has been in the hospital 28 days or more are automatically eligible for the program. But what about the others? How and what to look for in regards to eligibility is important. Next to actually getting in contact with the family, this is probably the hardest part. Will this baby be eligible? Unfortunately, there isn't a good tool to aid eligibility determination for these infants. Again, this is why observation during intake is so critical. We have to look at these little ones through a different lens. They are not typical. Nothing about them, from their time in utero to going home, has been typical. Typical babies are not exposed to toxic substances, and sometimes multiple substances, multiple times a day. Typical babies do not have a stressful birth experience that may be attributed to mom's substance use. And typical babies do not go through withdrawal or need drugs to manage symptoms of withdrawal. During eligibility determination, you may need to look closely at what is atypical about them, along with clinical judgment based on medical records, if you have them, and the observable information reported from intake. However, there are times when they may just not be eligible at this initial time for referral. Be prepared, though, for future referrals. These are sleeper referrals. They come in around the ages of 12 to 18 months, and new problems may emerge. This is something we are seeing more and more in the Shenandoah Valley, particularly with the substance-exposed infants. During eligibility, ask yourself, are staff knowledgeable about the nuances of a substance-exposed infant, or actually even toddlers? Because I mentioned just before, we're seeing more and more substance-exposed toddlers being referred. Are your providers comfortable with using clinical judgment to determine eligibility? Is there a good way to document observation during intake? But what if you just aren't sure? As with any child, if the team feels there isn't enough information to determine eligibility, the team can recommend an assessment. Kelly will share with you information from a provider's viewpoint on things to be aware of and consider during the assessment period.
Thanks, Charlene. So I want to start off by asking, how do you feel about your ability to identify atypical development in a 1 to 3 month old baby with a diagnosis of neonatal abstinence syndrome? I'd like you to use your polling tool to make a selection here. Jeannie went, okay. Perfect timing. So I see most of you say you're fairly confident, but then we also have a few not sures and need more information. And I appreciate the honesty there. Because the first thing we should address when we think about the program implications for the assessment for service planning is that there are no real good tools. The signs and symptoms of NAS can continue at varied levels for 3 to 6 months after discharge, and it's going to look differently over time and different with every baby. Because of their age, you may be asked to do an assessment on these babies when they don't really have enough functional skills to be able to identify a delay. As a service provider, you're going to need to rely more heavily on informed clinical opinion, clinical observations, and parent report during this process. It's important to know the questions to ask and what to look for to identify what is often atypical functioning. This ASP requires a skilled early intervention provider who knows how to identify self-regulation challenges and atypical early infant development. Now, this could easily be a standalone webinar, but in the interest of time, I'm going to share with you what I've been observing when I follow these babies from hospital to home. And I start with those original functional skills of eat, sleep, and console. We talked in part 1 about dysrhythmic suck, swallow, breathe coordination in the baby with neonatal abstinence syndrome. They have a hyperactive brooding and sucking reflex that impacts oral motor planning. They also demonstrate excessive sucking behavior in an attempt to self-soothe. These babies want a pacifier or hands in their mouth, or they're clutching their face. They're very oral driven, and this can be confused as a hunger cue. The baby with NAS is gestationally ready to eat, but neurologically disorganized. They also have frequent gastric distress and digestive irregularity from the withdrawal. By the time they go home, the baby's oral motor coordination is functional for eating, but often they're still showing an excessive suck and very high oral seeking behavior. The baby with NAS is wired to seek out non-nutritive sucking to help organize and relax, and they still rely on the pacifier or their hands. They're still working on trying to be a good self-regulator, but the caregiver confuses this cue with hunger, and I often hear, he or she is hungry all the time. They want to eat every hour or hour and a half, and they spit up after every feed. In general, term newborns that are bottle fed should be able to go 3 to 4 hours between feedings. Breastfed babies eat a little more frequently, but should still be able to go 2 to 2.5 hours between feedings. If you give the baby with NAS the bottle, they will take it, and they will become patterned to expect it. So misreading this cue often results in overfeeding, which causes spitting up, gassiness, difficulty burping, constipation, and rapid weight gain. Remember, these babies aren't good self-regulators. They don't give good cues to indicate they're full until they're arching and crying, and then they spit up. The baby is constipated, parents are switching formulas, pediatricians are prescribing reflux medication, and I see a baby that still remains in gastric distress. When a baby is having excessive oral seeking behavior and can't pace their feedings and doesn't provide good cues of hunger and feeling full, this is atypical behavior. Sleeping. Sleep is powerful for infants. It's when nutrition is converted into fat and protein. Weight gain occurs and bone length and density increase. This is the time when neurotransmitter and synaptic connections are strengthening and building. So I ask the parent about the pattern of sleeping over a 24-hour period. And I'll often hear that the baby only takes 15 to 20-minute cat naps during the day and maybe gives them a 4-hour stretch at night. On average, a term baby in the 0 to 3 month range sleeps at least 14 to 17 hours in a 24-hour period, and some sleep as much as 18 to 19 hours a day. The typical baby in the 0 to 3 month range has a sleep-wake cycle of 50 to 60 minutes that includes brief periods of arousal where they may wiggle, stretch, and frown. But they don't fully awaken, and then they go right back into that cycle again. This can last for 2 to 3 hours, usually until it's time to eat. In general, The typical sleep pattern in early infancy is light and restless, and they may appear to be waking up when they really aren't. The baby with NAS is characteristically high alert, high arousal with a low threshold for stimulation. The disruption of their sleep-wake cycle is much more easily triggered, and it's going to be harder to quiet him or her down and get them resettled, and so they ultimately sleep less. So little Jamal says, when I don't sleep, I'm overtired and fussy, so I want to suck to soothe myself. I'm so voracious around my mouth that Dad thinks I'm hungry. And Dad's tired too, by the way. And so he gives me a bottle. But wait, didn't I just eat an hour ago? Oh well, never mind. I like that nipple in my mouth. Can you see the cycle that's potentially developing here? When infants don't have any or very few sustained periods of sleep over 24 hours, this is atypical development and can lead to other routines that negatively impact development. Every newborn is constantly striving to control and organize sensory input. The ongoing challenge to actively regulate their behavioral state while processing stimulation demands self-regulation. There's a reason babies under 3 months of age sleep a lot. It's how they're learning to manage sensory information. But the baby healing from NAS struggles with the ability to develop this regulating capacity. Observing these babies, you may see a high alert, high arousal state compared to their same age peers. By this, I mean the baby's hypervisual and hyperreactive to environmental stimulation. I've seen some with a startle reflex that persists until 6 months of age. What you may at first observe as advanced is actually atypical when you consider their age. This leads to easy overstimulation and a rapid transition from engagement to irritability. Every baby has a different sensory trigger, but once they cross that threshold, it takes a long time and sometimes multiple strategies to calm them down. This is atypical behavior. I use the analogy of the racehorse in the gate, that when the gun goes off, they bolt when the door is open and they run full speed around the track, hyper-focused and driven, an amazing athlete. But when the race is over, the horse is still running. He can't stop. He's sweating, visually distracted, and easily agitated. The jockey has to spend time working him back down to a calm state, sometimes going a whole nother lap around the racetrack. This behavior is often characteristic of the baby healing from NAS. And parents don't know that these early challenges with eating, sleeping, and consoling are atypical. But we know that these behavioral patterns are potentially early markers of later emotional, behavioral, and cognitive challenges. So we talked in part one about the potential effects of drugs on pregnancy and birth. And now we've just talked about neonatal abstinence syndrome and the impact of this on development in early infancy. So I'm curious to know, what kind of drug use do you see impacting your community? Looking at those 4 main categories, can you share with me in chat for a second? Tend to see where you live. Thanks. I think as you can see, everybody's pretty much seeing everything or some combination and in their community. And this is pretty consistent across the state of Virginia. So looking at these categories of tobacco, marijuana, stimulants, and that includes cocaine and methamphetamine, and opiates, I want you to refer now to handout number 2 to see what we know about the potential effect of drug exposure on central nervous system development, cognitive function, and behavior. We're going to go drug by drug category. So with tobacco in infancy, we're going to see excitability, hypertonia, and stress abstinence syndrome. But later we see conduct disorder, aggression, antisocial behavior, impulsivity, ADHD, and possible lower IQ. With marijuana, in infancy we may only see mild withdrawal and some delayed state regulation, but later we see language delays, reading and spelling difficulty, and executive function impairment. With the stimulants, in infancy, we're often seeing autonomic instability, state regulation challenges, motor asymmetry and jitteriness, and poor clarity of infant cues during interactions. And with methamphetamine, we're specifically seeing poor movement quality and increased physiologic stress. And later, we see general cognitive delay and sensory processing delays with stimulants. With opiates, as we've been talking about, in infancy we see neonatal abstinence syndrome and dysrhythmic swallowing. And we're also seeing a very high incidence of strabismus and torticollis. Later, we see anxiety, aggression, feelings of rejection, disruptive inattentive behavior, and possible delays in general cognitive function. Remember, the baby with NAS often has polysubstance exposure, as you saw by your comments in chat. So developmental risks increase and are going to cross categories. What does this mean? In August of this year, the American Academy of Pediatricians released the first long-term study using data from Tennessee. And during the time period 2008 to 2011, they compared infants born with NAS to infants born in the same period without NAS, a 1-to-3 ratio. And then they linked this data with the Tennessee Department of Special Education data during the early childhood years of 3 to 8 years of age. And what they found were that children with a history of NAS were more likely to be referred for a special education evaluation, more likely to meet the criteria for a disability, and more likely to require classroom therapies or services compared to their same age peers. So as this early study shows, I believe we're going to see preschoolers in Virginia with a multitude of developmental challenges in the cognitive, language, and social emotional domains. How can early intervention have an impact? I'm going to give the floor back over to Charlene, who's going to share some insight on IFSP development for these families. Charlene?
Thank you, Kelly. When we go back and to meet with the family to develop the IFSP, as with any family, we're going to look at their priorities, their concerns, and then work on the outcomes. Again, remember that their priorities and concerns may be, like any other family we work with, not what we are looking at as priorities and concerns. So what they may be thinking for outcomes may be totally different. This is also a great time where, again, we need to educate the parents. And I hope that you've picked up on a common theme throughout this, that parent education is very critical. You may need to go back and review with them what you observed or what you talked with them about during the intake or during the assessment. Like Kelly mentioned, you want to talk with them about the feeding and sleeping patterns of their baby. Parent education is really, really important on their baby's behaviors and how their baby looks compared to typical behaviors. You might be able to present them with visual tools to help educate them. But you want to remember to present the information in a factual manner and with compassion. You want to help them see or learn or know that what their baby may be demonstrating now as a typical development can impact later development. You don't want to scare them, and you don't want to make them feel guilty. You want to be totally non-judgmental. Many times you'll hear families say, well, I don't really know, or I don't have any concerns. And that may be okay, and then we want to work with that. But sometimes services may change throughout the first even few months. You may have families that start out with service coordination only and then move into physical therapy or maybe speech and language therapy. Be prepared to be flexible like with any other family. When a family wants service coordination only, there are things to consider. Again, going back to their priorities. If at that point in time their priority is maintaining sobriety or finding housing or getting to counseling, those are things that as service coordinators we need to be thinking about. How can we support them in that process? Again, how well has the family been educated along the way on what to expect regarding their baby's development and the risk factors, and being careful not to place blame. And if service coordination only is important to the family, relationship is important also. So maintaining contact with that family is critical. And that's more than just a monthly phone call. Monthly face-to-face contact will help maintain that relationship and help you maintain contact with that family. Complete ASQs together and look at what's going on with their baby at that point in time. Be prepared to answer their questions. However, if we now start to look at how we present information to these families at the very beginning and begin to build that trusting relationship and educating the family, we may not have as many come through asking for only service coordination. We may be able to get in and work with some of these babies with the atypical development sooner versus than later. So what does this all mean for your program and what you do as an early intervention provider? As with any family, we want to look at capacity building. We want to look at building those relationships, not just with the families, but with other referral agencies and within our own program. We want to build a network of support within the program to have your own subject matter experts within your program who can work with these families. But again, going back to building that trusting relationship with the family will be critical and key in order to get in to work with the babies that are found eligible for services. Building collaboration with your referral agencies, with your hospitals, with your pediatricians, going to be very important, especially with those families who are very challenging and difficult to contact, and those babies who truly are at high risk for further complications down the line. And finally, education. Education in your community, education with your referral sources, education with the families, and education within your own providers and own programs. Helping them understand the importance of the substance use disorder as an ongoing disease of the brain that will impact them lifelong. In the chat, I would like you to share one takeaway that you have from today, or something that you may try differently in the program, in your own program. So take a few minutes and write something down in chat, and we'll try to share those as we go along. Take more time to observe babies and families more closely. Yes, that's a good one. And as Corey mentioned, we do have some of these tips and strategies along with some of the resources on your additional handouts for you to refer to. Importance of overfeeding and looking more carefully at hunger and self-regulation instead of assuming the baby is hungry, right? That's a good one. And awareness of the impact and how it unfolds over the course of the child's life, even years later. Very true. It's really important. As I mentioned, we are beginning to see more and more referrals of the little ones coming back who are 1 year to 18 months of age with language and behavioral concerns. Kelly and I hope that you've enjoyed this presentation, and I'd like to open this up right now for any questions that you may have. If you'd like to put them in the chat box, and we'll do our best to answer them. You're right, Corey. It will be interesting to see the current child as they enter kindergarten. Could you explain more what is in the plan of safe care, and is it shared with early intervention providers?
I can comment on this. So the plan of safe care as it's developed in the hospital is it's a component. The discharge plan focuses on both the needs of the mother and the baby after discharge. And so oftentimes this is going to involve CPS. And then if the mom is involved in medically assisted treatment program or if she needs to go to treatment, oftentimes that is the plan that's going to be managed after discharge. And I know the state is right now trying to figure out who's sort of in charge of managing that plan of safe care. I think in both Charlene and my community, Child Protective Services does seem to be managing it. There are parts of that that can be shared with early intervention providers, but as we know, anyone who seeks substance use help is entitled to privacy, and that does not have to be disclosed to the early intervention program. So there is a pamphlet available that we can include where you can read a little bit more information about that. Oh, I see, Charlene, you wrote about that reference also on the handout. That's perfect. So I think it's important to understand that we may have some of the information, but not all of the information, because mom is entitled to her HIPAA privacy as well.
That's right, Kelly. And we hope that this presentation has given everyone a better insight into the importance of understanding neonatal abstinence syndrome and how stress impacts the substance-exposed infant, and has given you a greater awareness of substance use disorder as a brain disease and the importance of being able to accept this in order to build a trusting relationship, and has challenged you to think about how you work with these families in your own programs. Thank you.
Charlene and Kelly, this is Corey. I want to thank you for sharing your expertise. I hope everybody has gotten some good information and is able to use this Talks on Tuesday and all of the resources that Charlene and Kelly provided to you. I'd like to invite everybody to our next Talks on Tuesday series. The first one is November 6th, and it is going to be about the decision tree, a tool for teaming and family engagement. We will have Lisa Terry from the PD team and Kyla Patterson presenting. So thank you all for joining us. You will receive a survey at the end of our Talks on Tuesday. When you complete the survey, you will get your certificate of participation. Let's see. I was looking to see. Kelly, we have one more minute. What do you know about, I don't even know, Suboxone and breastfeeding?
So I did quickly put a response in there. So basically, mom is allowed to breastfeed if she is in a medically assisted treatment program, even if she's on methadone or Suboxone, because only 1% is going to transfer through the breast milk. Moms who are not advised to breastfeed are those that are HIV positive, or if the mom is not in a substance abuse program, meaning that there's no way to track what she is using. But our moms that are in a MAP program are encouraged to breastfeed.
Thanks, Kelly. And I see that it is 1 o'clock, so we are going to honor your time. Again, thank you for joining us. Please do join us in November, and have a good afternoon. Thanks, everybody. Bye-bye.
Bye-bye. Thanks.
Thank you.